Auzubillahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. On behalf of ADCO Laboratories, I welcome our two honorable guests, Professor Ziaul Mazhari Sahab from Lahore and Professor Khalid Talpur Sahab from Hyderabad. Before starting the webinar, I would like to introduce myself. I am working in ADCO Laboratories as a business manager. ADCO Laboratories is the leading pharmaceutical company in Pakistan and get the 11th rank in pharmaceutical industry. It's about 18 billion company which manufacturing different type of medicines, including cardiology, dermatology, and serve in dermatology, cardiology, ophthalmology, gynecology, and pediatrics. And now I will request for the recitation of request to Professor Ziaul Mazhari Sahab for the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر صدق الله العظيم. زمانے کی قسم، بے شک انسان نقصان، خسارے اور گھاٹے میں ہے، سوائے ان لوگوں کے جو ایمان لائے اور نیک عمل کرتے رہے اور حق بات کی تلقین اور صبر کرتے رہے. اسی تناظر میں رمضان کی آمد ہے، تو میں آپ کو ماہ قرآن کے نام سے ایک تازہ نظم سناتا ہوں. رحمت حق کا جہاں پہ صاحبان آ گیا، ماہ قرآن آ گیا، ماہ رمضان آ گیا. خوش نصیبوں کو ملی پھر سے مبارک ساعتیں، انوار کا پرتو لیے پیارا مہمان آ گیا. دن کو بھوک اور پیاس سے، شب کو قیام اللیل سے، بالیدگی روح کا بھرپور سامان آ گیا. ماہ قرآن آ گیا، ماہ رمضان آ گیا. عشرۂ اولا میں ہیں دروازے رحمت کے کھلے، اہل ایمان کے لیے تحفہ رحمان آ گیا. ماہ قرآن آ گیا، ماہ رمضان آ گیا. عشرۂ ثانی ہوا مخصوص بخشش کے لیے، مجدہ لے کے مغفرت کا مہربان آ گیا. ماہ رمضان آ گیا، ماہ قرآن آ گیا. تیسرے عشرے میں تو قدر جیسی رات ہے، اور دوزخ سے رہائی کا بھی فرمان آ گیا. ماہ قرآن آ گیا، ماہ رمضان آ گیا. روزہ داروں کو ملی آخر میں شب انعام کی، لیجئے عید الفطر کا روز ذیشان آ گیا. ماہ قرآن آ گیا، ماہ رمضان آ گیا. جس نے رضائے رب کو کی پابندی صوم و صلات، پروانہ مقبولیت اے اہل ایمان آ گیا. ماہ قرآن آ گیا، ماہ رمضان آ گیا. زکوٰۃ اور انفاق سے ہو مال کی پاکیزگی، روزہ برائے تزکیہ جسم و جان آ گیا. ماہ قرآن آ گیا، ماہ رمضان آ گیا. رحمت حق سے نہ رکھوں کیوں میں بخشش کی امید، رحمت حق سے میں رکھوں کیوں نہ بخشش کی امید. زندگی میں مظہری پھر سے رمضان آ گیا. ماہ رمضان آ گیا، ماہ قرآن آ گیا. شکریہ. اوور ٹو ندیم صاحب.
Is that right?
That's right, sir. You can start.
Okay. Thank you very much. Okay, thank you very much, Nadeem, and thank you, Professor Zia Mazhari Saab. It is indeed a great pleasure to be with you and sharing my views about this important entity which we face every day in our practice. As we all know that glaucoma is a disease which is very common. Everybody face this disease. All the ophthalmologists, we are facing this disease and managing this disease. And this is a disease also causing the irreversible blindness. But while managing the glaucoma, we are having the other problems related to the management of the glaucoma that affect the quality of the life of the patient. So we are going to talk about correlationship between the ocular surface disease and glaucoma. We are going to share the talk, me and Dr. Zia Mazari. I'm going to first talk about the prevalence and the clinical manifestations and the introduction about the ocular surface disease in glaucoma. And later on, Dr. Zia Mazari is going to talk about the management and the prevention of the ocular surface disease. By the way, just to let you know that I'm Dr. Khalid Iqbal Talpur. I'm a consultant ophthalmologist here at Hyderabad. Now, first of all, let's understand a little bit about glaucoma, or know about the glaucoma. We all know glaucoma is the commonest cause of the irreversible blindness all over the world. Though it is the number 2 cause of the blindness after cataract surgery, but it is the number 1 as far as the irreversible cause of blindness is concerned.
Professor Khalid, we
Yes.
cannot see your slides. That's right. That's right. Please
Is that
go
okay?
ahead. Go ahead.
Okay. So first we are going to talk about a little bit about the glaucoma. We know that the glaucoma is the commonest cause of the irreversible blindness. Although overall it is the number 2 cause of the blindness after cataract, but as far as the irreversible loss of vision is concerned, glaucoma is the number 1. And we keep on managing these cases. The goals of the glaucoma management are to preserve the vision, and to preserve vision we have to control the intraocular pressure and bring it to a certain target level where the damage to the optic disc is minimized or completely reduced. Now this is the aim of the glaucoma management, glaucoma treatment. But whenever we are treating these patients, there are certain other factors which we have to keep in the mind, because these patients who are being treated, they are liable to suffer from certain complications, certain side effects of the drugs on the ocular surface, and that ultimately affects the quality of the life of the patient. So I'm going to talk about the relationship of the glaucoma treatment with the ocular surface disease. So it's very important to understand that when we are treating the glaucoma, simultaneously we have to look at the other problems related to the management of the glaucoma on the ocular surface. Generally, we tend to forget that, and generally we don't pay attention to it. Because we are looking at the intraocular pressure, checking the intraocular pressure, doing all the examinations of the glaucoma, like the examination of the disc and all other examination of the glaucoma, because we are more concerning about the intraocular pressure and its effects on the vision. And we tend to forget about the related other factors which affect the ocular surface and ultimately affecting the quality of the life of the patient. Like suppose I can tell you that a patient having long-term treatment on the glaucoma, he is doing a routine job or a routine work, and suddenly he started developing irritation, foreign body sensation, and that is affecting his work, that is affecting his quality of the life. So we have to take care of that aspect as well, to prevent the patient going into poor quality of the life. So just to revise that, the glaucoma treatment consists of lowering the intraocular pressure to the target level where the visual loss is minimized or stopped if possible. Along with that, we have to have a quality of life considerations like long-term impact of the medications, balance of the efficacy and the side effects, and above all, we should not do any harm to the other parts of the eye while treating the glaucoma. Now, after that introduction, I want to share with you that we all know that the ocular surface disease is common in the old age. As the age progresses, the dry eyes or the ocular surface problem also get worse. These are, I'm talking about the normal elderly, not the glaucoma patients. Now here you can see there are the two types of the graphs, one on the left side, one on the right side. Left side is related to the age and right side related to the gender. So these are actually showing the prevalence of the dry eyes in the elderly patient, and this was the study published in the American Journal of the Ophthalmology. If you see on the left hand side, there is a relationship of the age with the percentage reporting one or more symptoms often or all the time. So persons having the one or other more symptoms either present all the time or present occasionally.
सर
So you
आप
can see that
एक्सक्यूज मी प्रोफेसर खालिद, आपकी स्लाइड्स चेंज नहीं हो रही। अपने पावर पॉइंट विंडो से स्लाइड्स को चेंज करें साथ। इधर स्लाइड नहीं आपकी चेंज हो रही।
अब शेयर हुई?
जी बिल्कुल ठीक है, परफेक्ट। नेक्स्ट स्लाइड।
नेक्स्ट स्लाइड, ओके। अब शेयर हुई?
जी ठीक चल रही है, प्लीज।
चले ठीक है, ओके। तो ये this is the slide where we are comparing the age with the symptoms of the patients. So on the left hand side you can see that with the increase in the age from 65 to 69, 70 to 74, the symptoms are increasing as the age is increasing. So this is how we know that with the age, the dry eye increasing. Similarly, here in the gender group, you can see the percentage of the female symptoms are higher as compared to the males. We all know that the dry eyes are commoner in the females as compared to the males. Now, this is the general overall incidence of the OSD in the elderly group. Currently, we are talking about normal elderly group, not associated with the glaucoma. So 14.6% have been reported to have one or more dry eye symptoms often or all the time. So this is the prevalence of the OSD in the elderly. Now again, age and OSD. On the left hand side, there is a woman health study. On the right hand side, public health study in the men. So left hand side, you can see as the age grows, the prevalence of the dry eye increases. If you see that in this 5th decade of the life, the prevalence of the dry eye is around 7%. But in 75 plus eye, the incidence is more than 10%. So with the age, in the women, with the age, the dry eye incidence is increasing. And similarly in the males also, the incidence of the dry eye is increasing. But if you compare the male and the females have got the more incidence of dry eyes as compared to the males. This is what we know, all of us, but this is how this study has proved this thing. Now that I was talking about the OSD in the normal population of the old age. Now we know that the glaucoma also happens in the middle age or the old age, is common in that age. Along with that, the dry eye is also common in the old age. So now we are facing the glaucoma patients at risk of developing the dry eyes. Either the patient is already having dry eyes, or the patient is at the higher risk of developing ocular surface disease or dry eyes once we start the medication of the dry eyes. So this summary of the ocular surface disease in glaucoma tells us that the ocular surface disease is a significant problem for many glaucoma patients. We must keep in mind that while examining the patient of the glaucoma, whenever the patient coming for the follow-up, we must look at the ocular surface. We tend to forget that. We tend to forget that because we are more concerned about the glaucoma, about the intraocular pressure, about the disc, and all the factors related to glaucoma. And we tend to forget looking at the ocular surface and related problems. Its prevalence is quite high. It is around 50%, which is between 48% to 60%. It means that the patients who we are treating with the medical therapy, who are on the medical therapy, half of them are going to develop the ocular surface disease, which is quite a significant number. So we have to pay attention to it. Previously reported a population-based study of the elderly showed about a 15%. And the other important thing we have to keep in the mind is that the severity of the ocular surface disease increases with the number of the medications used. We know that the glaucoma patients are sometimes using multiple medications. Sometimes they are using one medication, sometimes two, sometimes three medications. So if they are increasing, they are using multiple number of the drugs, the ocular surface disease severity increases along with that. Now I'm in this slide, I'm going to show you that what pathological changes which take place in the ocular surface disease. In this Glaucoma Today journal, this was presented that the ocular surface disease is a condition that adversely affects the stability and the function of the tear film. The common causes of the ocular surface disease are dry eye syndromes, blepharitis, meibomian gland dysfunction, and preservative toxicity. We all know that these are the things which are related to each other. So when we are examining a patient with the glaucoma for the pressure and for the optic disc examination, we must not forget looking at the tear film. We must look at the eyelids, looking about the blepharitis, looking about the meibomian gland dysfunction, and also very, very important is the preservative toxicity, because the drugs we are using, they have got the preservatives in it, and these preservatives are toxic to the ocular surface like conjunctiva and the cornea. The epithelia are very susceptible to be disturbed or dysfunctions or damaged by the toxicity of the preservatives in the drugs. The pathological changes taking place on the ocular surface are the corneal epithelial cell changes, decreased goblet cell density in the conjunctiva, and increased inflammatory mediators released from the ocular surface. So these are the pathological changes which are taking place on the ocular surface in a patient in glaucoma using the medical therapy. So now people are talking about the quality of the life in the patient with the glaucoma. what do we mean by the quality of the life is that a patient of a glaucoma, if he's using the drops, we are controlling intraocular pressure. Other than that, if patient's eyes are normal, there is no irritation, there is no foreign body sensation, there is no watering, there is no lid problem, it means the quality of the life of the patient is not affecting the patient's work. The quality of life is better. So if a patient with the glaucoma is on the control with the medical therapy, and there are no associated other problems, it means the quality of the life of the patient is good, and he or she can carry out their routine life activities in a normal way without any disturbance. So whenever patient of the glaucoma comes to us, we have to talk about the quality of the life with the patient. We have to ask to the patient, how is your quality of the life? Is your work is being affected? Is your routine life is being affected? So this study, which was published in the American Journal of Ophthalmology, this proved that ocular surface is more common in patients. Ocular surface disease is more common in patients with increasing glaucoma severity, and is associated with the pooring glaucoma related quality of the life and higher exposure to BAK. So in this slide, I'm conveying message to our colleagues that when we are treating a patient with the glaucoma with the medications, we must look at the quality of the life. How is the quality of the life of the patient? Now, whatever the disturbance happen on the ocular surface, there are certain measures, or there are certain ways to quantify this ocular surface disease. And this is important for documenting any claims of improvement in response to the treatment options. Now, this is a term we use, ocular surface disease index. This was developed by Ocular by Outcome Research Group, in which there was a questionnaire. In that questionnaire, there are 12 items. Now, these items provide us a rapid assessment of the symptoms of the ocular irritation consistent with dry eyes. So we can know that the symptoms, how many symptoms are there, quality of the symptoms, type of the symptoms are there, and that will give us the ocular surface disease index. This is designed as endpoint in clinical trial testing of treatment of the dry eye disease. Now, this is the ocular surface disease index severity grading. In this, if you look at this, that if the score, this is 0 to 12, these are the scores of the ocular surface disease. If the score comes 0 to 12, it means there is no ocular surface disease. There is normal ocular surface. If the score comes between 30 to 22, then it is a mild ocular surface disease index. If it is between 23 to 32, then it is moderate ocular surface disease. If it is between 33 to 100, then it is severe ocular surface disease. So this is how we can quantify the ocular surface disease for the diagnosis, for the management, and for the results of the treatment which we are when we start for the ocular surface disease. The total ocular surface disease is equivalent to the sum of the score of the all questions answered multiplied by 25 and divided by total number of the questions answered. So this is a term people are using when particularly they are doing trials for the ocular surface disease to identify the disease and its severity and management of the ocular surface disease. Now, that trial, look at this OSD index results in 670 glaucoma patients, uh, in which it was found that almost 51% of the patients, they were found to be normal because they were not found to have an ocular surface disease. It means the half of the patients of the glaucoma using the medical therapy, using the drugs, half of them, they remain normal. And half of them, almost 48.4%, they develop ocular surface disease. So it's very important to identify that which patient of the glaucoma on medical therapy is having the ocular surface disease, so that we can identify those patients and manage them. The out of 48.4%, 21.3% were found to have a mild ocular surface disease, 13.3% had a moderate ocular surface disease, and 13.8% had a severe ocular surface disease. This is a very, very important data which gives us the evidence that how do we manage our patients of the glaucoma having ocular surface disease. First, we have to identify. It's very important that this patient is either having the ocular surface disease or not. If it's having normal, that's fine, no problem. We will continue medical therapy and we are patient's ocular surface is okay. But half of the patients are having the ocular surface disease. Then we have to identify the severity of the disease, because we have to manage ocular surface disease according to the severity of it is. So this is evidence-based. The results on that basis, we are going to manage the ocular surface disease in case of the glaucoma. Now, this is a very important slide showing the impact of the multiple medications. We already discussed that as we increase the number of the medications, the ocular surface disease is going to get worse. So this slide shows that if you are using one medication, the OSDI score is 12.9. If we are using two medications, ocular surface disease index is 16.7. And if we are using three medications, ocular surface disease index is 19.4. So one, we have to identify if the ocular surface disease is there or not, and then the severity we have to know. The number of the, we should know that as we increasing the number of the medications, the chances of the ocular surface disease are higher if the patient is using multiple medications. This is any additional data given by Lewin that he evaluated of the various tests in OSDI index. If usually patient has 59% symptoms in one eye, 59% of the patients, and 27% reported severe symptoms. And Sharma test showed 61% decreased tear production, 61% patient shows decrease, and one eye had 35% severe deficiency. Leishman green staining showed 22% positive staining. Similarly, tear breakup time showed 78% patient had an abnormal tear quality and 65% showed severe decrease in the tear quality. This is important data which gives us that the ocular surface disease is common, and various tests they show that the positive results in ocular surface disease being in the patient being treated with a medical therapy. So the key learnings are: large proportion of the patients with the open angle glaucoma or ocular hypertension had signs and symptoms of OSD in at least one eye. Large proportions, maybe more than 2/3. The coexistence of OSD, ocular surface disease, and the use of BAK containing medications may impact vision related quality of the life in patients' population. The lack of concordance between signs and symptoms presents a problem to the diagnosis of the disease and assessment of the severity. So it's very important we should correlate the sign and symptoms of the symptoms of the patients for the diagnosis and the assessment of the severity. Now, in the end, just to conclude that ocular surface disease exists in the old age, normal old age. Incidence is around 15-16% of the general population have dry eyes. Females are affected more than males, and ocular surface disease is worse in use of the glaucoma medications. This is a very important point we must understand. And in the last, ocular surface disease in the glaucoma affects quality of the life, and we have to pay attention to this very important aspect. While treating the patient with the glaucoma, we must pay attention to the quality of the life, by which we mean that the other problems of the symptoms of the eye, like irritation, foreign body sensation, giddiness, they affect the quality of the life, and we have to look after that and try to keep the quality of the life as much better as possible for the patients of the glaucoma. So thank you very much for the patient's hearing. I hope I conveyed my message to you, and thank you very much. Now I transfer my mic to Nadeem for the further webinar continuation. Thank you all for patience hearing.
Thank you very much, sir, for excellent presentation. Nadeem, please.
Wonderful and very informative presentation. It's very easy to understand how we have the problem associated with the glaucoma because of, as you tell, that patient using multiple drugs, using more OSD as compared to those who having just one OSD. So now we like to invite Professor Ziaul Mazhari for another presentation regarding to the same subject, is the OSD and glaucoma. Professor Ziaul Mazhari sir.
Thank you, Mr. Nadeem, and thank you, Professor Khalid Talpur, for enlightening us with and creating this awareness of coexistence of ocular surface disease in glaucoma patients. And as Professor Khalid Talpur has explained very well the magnitude of the problem, the prevalence and the mechanism, and he also touched the guidelines, basic guidelines. We will be discussing in this presentation more about prevention and management of ocular surface issues with lifelong glaucoma treatment. And as you have seen in the whole presentation, glaucoma and dry eye, a tough combination, a tough combo. And the clinicians, as ophthalmologists, we need to take care of both the problems together. Glaucoma and ocular surface disease may coexist, and even we need to keep that in mind, that the patients who need glaucoma treatment, the ocular surface problem or dry eyes may be pre-existing in those patients. So right from the baseline, we need to evaluate the patients for ocular surface problems. The diseases may be concurrent or concomitant, and it's important to attend to each disease on case-to-case basis and plan treatment strategies accordingly. Glaucoma and OSD are comorbidity, and even in recent studies, GOSD, glaucoma and OSD terminology has been coined. And as we all know that the ocular surface and the dry eye issue has been addressed in cases of refractive surgery, in cases of cataract surgery, and many guidelines and protocols have been used and it has been under discussion. But coexistence of this comorbidity along with glaucoma is a relatively recent discussion taking place on forums of ophthalmology. And a very interesting fact is that the 72% of the total body mass of young adults is water. And this decrease in body water can cause ocular surface disease symptoms. At birth, the body water is approximately 80% and it decreases to 60% in the patients older than 65 years of age. And in late years, body water content is below 60% of the body mass. As the water content is related to the symptoms of ocular surface disease and with age. So this interesting facts tells us another thing, that the age is related to appearance of symptoms of ocular surface disease, and at the same time glaucoma is also, the risk of glaucoma also increases with age. So with increasing age, the comorbidity of ocular surface disease and glaucoma show increased incidence. That's why in the population which is more prone to glaucoma and in which we are about to initiate or have already initiated glaucoma treatment, we must take into account the ocular surface disorders, and a baseline evaluation and a kind of concurrent evaluation of ocular surface issues should be there on each visit when the patient visits to ophthalmologist for glaucoma screening or glaucoma follow-up. And as Professor Khalid Tarpur pointed out, the glaucoma and coexistence of ocular surface disease can really hurt and impair the quality of life. And what we can do, he has already touched these issues like scrupulous eyelid hygiene, avoid contamination. Do we need to educate the patients about makeup issues and long stay of makeup substances without washing the eyes and with wipes and rinsing with it water may irritate the eyes further. Warm compressors have their role, washing lids and clean washcloth, using shampoo to lid hygiene are the regular issues. They must be kept into mind while taking care of glaucoma patients. Importance of early diagnosis of OSD in glaucoma patients, as you understand that the environmental and situational challenges should be addressed. The visual tasks of the particular patient should be kept in mind, like reading, using screens, and arid conditions such as airplane cabins may also aggravate the conditions. So as you may see that it is just as if we are discussing dry eye syndrome independently, all those measures have to be kept on lifelong glaucoma therapy patients as well. Early diagnosis and proper identification of the ocular surface issues with glaucoma and prompt action is the need of the hour. So how can we preserve the ocular surface? Number of options for treating glaucoma are medications. Most of the medications available are medications with the preservatives. The second option is preservative-free drugs. And unluckily, none of the preservative-free drugs are available in our local market. The third option is to use soft or disappearing preservatives. And as you know, this webinar is being sponsored by ATCO, and they are manufacturers of one of the anti-glaucoma combination that is with the name of Glantrim, that is drosolamide with timolol, and it contains a disappearing preservative that is sodium perborate. So this is one of the only options available locally in the market. We don't have preservative-free drugs, so this is a better choice to treat patients with ocular surface issues. The treatment of OSD with punctal plugs may facilitate both. When I was going through the literature, there is a study which shows that if the punctal plugs are placed at the right time, they help the retention time of the dry eye medication, drops, solutions, as well as retention time of the anti-glaucoma drug will be increased, and it will help both in managing the ocular surface as well as the IOP lowering effect of the anti-glaucoma drug will also increase. And we need to consider the compounds like cyclosporine and steroids or immunomodulation and all the measures which are available for management of ocular surface in lifelong glaucoma therapy patients as well. Tear substitutes do help, and as you know that the preservative dose increases with number of the drops or the number of the bottles the patient is using, and the most notorious preservative is benzalkonium chloride. The more number of drops you add, the more is the risk of epithelial toxicity. And that's where the role of sodium perborate comes into picture, and you need to use the topical tear substitutes which are either preservative free or contain a disappearing preservative like sodium perborate. And at the same time, we need to prefer the anti-glaucoma drugs which contain disappearing preservative or which are preservative free in the shape of minims. And as you know, the preservatives help to control the microbial activity or contamination of the bottle. That's why the minims come into the picture. And oxidative preservatives like sodium perborate or Sofzia, they help by protecting the cornea and by modifying the tear film. So when BAC is used, the risk of the epithelial damage increases. And in chronic ophthalmic conditions, the more bottles we add, the more toxicity of the BAC will be there. So thus, that shows the importance of combinations as well. By using the combination in glaucoma therapy, we will be decreasing the number of bottles, and thus the dose of the preservative will also be accordingly decreased. Pathogenesis and prevalence has already been discussed. So these are the epithelial toxic effects of BAC preservative. So the single most critical advance in the treatment of dry eye came from the elimination of preservatives such as benzalkonium chloride. So implications of glaucoma therapy, as we have already discussed, that we can decrease all the complications of ocular surface problems like haze, infiltrates, ulcers, irritation symptoms, and quality of life can be improved if we are conscious of what preservative the drug we are prescribing is used and what kind of combination the best will help the patient once we are considering the tear substitutes. And these are the concentrations of BAC in various combinations or anti-glaucoma agents. So the more drugs we add, the more dose of the back will be delivered to ocular surface. A major cause of intolerance or poor tolerance to glaucoma medication is the ocular surface changes created by the treatment. The clinician need to keep that in mind as well. So new preservatives, as we have already discussed, sodium perborate is converted into hydrogen peroxide and acts as an antibacterial, and then is converted into water once in the tear films. So our sponsors, EDCO, has one of the agents with the name of glantrim, who is preserved by sodium perborate, as well as it contains HPMC. So it is ocular surface friendly combination. So it gives zero toxicity to the eye, and the glantrim offers effective management of glaucoma and the corneal surface or the ocular surface at the same time. So this is a typical evaluation of a dry eye and a glaucoma patient, and we all know the basic glaucoma measurements and tests, and even OCT and the dry eye analyzers can be incorporated right from the beginning while managing the glaucoma patients. Innovations in drug delivery for glaucoma management include ocular inserts of bimetoprost, travoprost, and latanoprost punctal plugs are becoming available. Latanoprost eluting contact lenses, and then bimetoprost and travoprost intraocular implants are also being considered and soon to be available in the market. And then the compounds are being researched like catioprost, which is a preservative-free cationic emulsion containing 0.05% latanoprost, and is being developed to control IOP while treating the ocular surface at the same time. In summary, evaluate glaucoma patients with holistic approach, treat the patient as a whole, and evaluate the patient as a whole. Take special care to note any pre-existing ocular surface disease. Consider impact of ocular surface disease on glaucoma patients' quality of life. Educate the patients about glaucoma and comorbid conditions like ocular surface disorders. Be ready to choose alternative glaucoma therapies. Minimize the use of preserved topical glaucoma medications. Use glaucoma medications with disappearing preservatives. Initiate OSD treatment at any stage once you realize that ocular surface disease is coexisting. Address both diseases concomitantly depending upon the stage of the glaucoma, severity of the OSD, and the therapies available in the local market. Choose combination topical therapies to minimize number of drops and thus minimizing the dose of back or preservatives to the ocular surface. These are the two articles which I have found very useful in understanding the management and prevention of ocular surface issues. One is from Review of Ophthalmology, the other one is Dual Dilemma of Dry Eyes. Conclusion. In general, the intervention center around two guiding principles: minimize the effect of glaucoma therapy on ocular surface and recognize and treat OSD as early as possible in the management course. So take home message from today's webinar is, as a chronic and sight-threatening disease, glaucoma treatment demands lifetime management and strict compliance. And we all agree effective management of glaucomatous OSD ocular surface disorder will lead to improvement not only in long-term visual outcomes but also in patient compliance and quality of life, and thus more satisfaction with the care you are providing as ophthalmology care provider. In the end, I will just go through my poem. You may have listened it already with the name of Chashme Khush, and you will enjoy it again in today's webinar. हमने देखी हैं वो वीरान वो सहरा सी आंखें, अश्क तर को तरसती हुई प्यासी आंखें. We have seen those desert-like eyes longing for a drop of tears. सुर्ख इतनी के लहू जैसे टपक जाएगा, दर्द से चीखती चिल्लाती हुई रोती आंखें. Deep red, like the blood will start flowing from the eye, and crying with pain and with the hurt of ocular surface disorder, weeping eyes. रेगजारों में भटकती हुई भारी पलकें. It's like the eyelids are wandering in the deserts. नूर से डरती हुई किरणों से उलझती आंखें. Photophobic and afraid of light rays. Those painful eyes. इतनी उलझन के कोई नोच के फेंके दीदे. The miserability or the misery is such that the one wants that the eyes may be removed even. टिमटिमाती हुई जलती हुई बुझती आंखें and burning with the itching and kind of dying eyes. कतराए अश्क जो सीराब करे किश्ते वीरा. Searching, longing for a tear which can irrigate this barren desert. चारागार ढूंढती फिरती हैं सवाली आंखें. And the dry eyes are still in search of an ideal tear substitute. And what a blessing this single teardrop is, even if we are able to manufacture a teardrop which resembles the provided by Allah the Almighty. How will we supply it the way Allah is doing for lifetime of the patients? So this is a big question, and what with the available knowledge we need to address whatever we can do to manage ocular surface and the glaucoma at the same time. So dear participants, we are open for the Q&A now. Dear Professor Khalid Talpur, can you come up with any comment?
Yes, I think this is practically is a problem, very common problem. And I've got a comment, so I'm just going to comment on it. And we come across every day this problem, and I think we generally try to ignore this problem, ocular surface disease, particularly associated with the glaucoma, because glaucoma itself is a disease which causes the blindness, and we are more worried about the blindness, and we are thinking about the intraocular pressure, we are thinking about optic disc, we are thinking about controlling the intraocular pressure. Simultaneously, we are paying less attention to this ocular surface disease. And so I think it's the webinar gives a message that the patients with the glaucoma needs good attention regarding the ocular surface. So I will advise to my all colleagues who are present, who are there in the webinar, to pay attention to this important entity and keep the quality of the life of the patients of the glaucoma to a level that his or her routine activities which they are doing in their routine life, they should go unhindered, and patients should have a normal quality life and go on routine activities normal. So I think in this regard, the ETCO have given us a good choice, in form of galantrum, which is available, which is a thing which is least toxic, the preservative in it, and with this we can control the IOP as well as we can control the ocular surface and keep the ocular surface in a good healthy condition. So I think this is a very good choice with us, available in our armamentarium, or the drugs available, the choice of the drugs available to us for the treatment of the glaucoma, which looks after the ocular surface in a good way. So this is the thing. I think ATCO has done a wonderful job at giving us this choice. So these are my comments regarding the today's talk.
Thank you, Professor Talpur. And at the same time, we appreciate the presence of ocular surface lubricants like Visol gel It's also a very good compound which contains, again, I think, disappearing preservative. So these are the compliments.
One comment from my side. What a nice pen I live in. And also one of the most important thing is that the translation you have, uh, your translation in English is also wonderful.
Thank you. Thank you. And at the same time, I will invite the participants. They can raise hand and we will enable their video and they can share their comments live here. Or raise your hand or type your question. We will love to answer. And Dr. Waqar Ahmed Ghauri has commented in the chat box that he has a very good experience with Viazole gel. We agree to it. It has been one of the major breakthrough compounds available locally to treat ocular surface related dry eyes and issues. And we are glad that we had a very healthy participation of around 50 participants in today's webinar. And we hope that we will continue this activity with more and more topics, and even surgical ophthalmology will be touched in future webinars. So we agree with Dr. Waqar Ahmed Ghauri that we also have a good experience with this compound and a combination of this, and we are eagerly awaiting for preservative-free anti-glaucoma treatment to be available in Pakistan locally. And but at the moment, we are glad that we had ATCO Laboratories with us, who are one of the pioneers to supply at least a combination with disappearing preservative with the name of Glentrim. SmartSoft friend Rana Saab is asking if the Glentrim is the only preservative-free anti-glaucoma drug. Professor Khalid Tadpur, do you know about any other combination here which contains disappearing preservative?
I think currently I know that this is the only which is available as clearing preservatives.
Disappearing. And Dr. Mohabbat, he is from D.I. Khan, and he is just clarifying that he is from Dera Ismail Khan. Dr. Mohabbat, if you have any question, please come forward. Any other participant with any comments or questions is welcome. So if there are no more questions or comments, one of our moderators, Abdul Khalik, is typing. Let's wait what he comes up with. And we're happy that after a few initial glitches, the webinar went well, and hopefully we were able to. Is Drozolamide Prostimolol only Grantrim is back free? Yes, he has come up with the same comment as Professor Khalid Talput clarified that Drozolamide plus Timolol combinations, Glantrim is the only combination which is not actually preservative free, but it actually contains the disappearing preservative. That is a kind of soft, friendly ocular surface preservative. So hopefully we are able to create some awareness, and again I will repeat the message that always consider ocular surface disease even before initiating anti-glaucoma therapy. It may be pre-existing and you may need to initiate anti-glaucoma therapy with initiation of ocular surface care as well. So thank you very much ATCO Laboratories for managing this, and we are thankful to WOFA for providing us this virtual platform, this webinar room, and we are thankful to both WOFA and ATCO for bringing us together with one of the eminent ophthalmologists from Sindh, Professor Khalid Talpur. We are thankful to you, Nadeem, as well, So thank you all, and I hand over the mic to Nadeem to conclude the webinar.
Thank you very much, both you, Professor Khalid Talib Sahab and Professor Ziaul Mazhari Sahab. One of the very good, both give a very good presentation regarding OSD and regarding treatment of the glaucoma associated with the OSD. And thank you very much for your good comments regarding our product, Glantrim. As you know, the Glantrim is the combination of dorzolamide and timolol is contained sodium perborate, preserved with the sodium perborates, and sodium perborate, as you told before, that is a preservative, is an oxidative preservative. When it's contact with the tear film, is converted into water and oxygen. That's why I claim that is a benzalkonium free drug. So now again, I will like to thanks from EDCO and from my team. So gave us a very good presentation, and this is the end from my side. I hand over to Professor Ziaul Mazhari for ending remarks, sir.
थैंक यू वेरी मच. हमने देखी हैं वो वीरान वो सहरा सी आंखें, अश्के तर को तरसती हुई प्यासी आंखें. अल्लाह हाफिज, and we will meet very soon with some exciting new topic, inshallah. Allah Hafiz.
Inshallah. Allah.